Today, I will share 5 important things we must know about Foley catheters before starting inpatient rotations. Let's get started. Urinary catheters are categorized into non-invasive like condom catheters, external female catheters, and intermittent catheterization. Yes, intermittent catheterization is considered non-invasive. And of course, invasive urinary catheters, i.e. Foley catheters. Foley catheter is an invasive urinary catheter. The American Urological Association and the Infectious Disease Society of America recommend using non-invasive catheters, urinary catheters when appropriate. These methods reduce complications and improve quality of life, especially when patients can self-catheterize. In ICU, using external female urinary catheters has significantly reduced indwelling catheters used and the catheter-associated UTI rates. Now, knowing that, today we are discussing only invasive urinary catheters, i.e. Foley catheters. Let's first discuss the indication to place an invasive urinary catheter or Foley catheter. Of course, there are some indications when non-invasive urinary catheters are not helpful and Foley catheters has to be placed. These include the following: acute urinary retention or bladder outlet obstruction that cannot be managed otherwise. Accurate hourly urine output monitoring in critically ill patients, like patients with shock, acute kidney injury, or major surgeries. Again, we talk about critically ill patients. Perioperative use for specific surgeries, particularly urologic or prolonged procedures. And comfort care in end-of-life situations when moving the patients for toileting would cause distress. And to assist healing of open sacral or perineal wounds in incontinent patients. And finally, prolonged immobilization due to unstable spine or pelvic fractures. The following are considered inappropriate indication to place a Foley catheter. Just because the patient is elderly or incontinent, that's non-indication, or convenience for the caring team, or to get a urine sample when the patient can void, use a midstream clean catch instead. And of course, social reason without clear medical necessity. These are inappropriate indications. Remember this, every day a Foley catheter stays in, the risk of catheter-associated urinary tract infection increases by about 3 to 7%. Catheter-associated UTI can kill the patient. So if it doesn't meet appropriate criteria, do not place it. And if it is already in, ask every single day, does the patient still need the Foley catheter or not? Let's talk about the Foley catheter system itself. But before that, if you'd like to receive a summary of this video delivered to your email, kindly subscribe to my Substack page and newsletter. The subscription link is provided below in the description field. A properly functioning urinary drainage system should continuously drain urine from the bladder, maintain a closed sterile system to prevent infections, and prevent backflow of urine into the bladder. Let's break down the components here. The catheter itself comes in different sizes measured in French. Large sizes like 18 to 20 French are used in patients with hematuria or clots, while smaller sizes like 14 to 16 French are standard for routine use. The catheter has a drainage lumen, an inflation lumen for the balloon, and multiple drainage eyes at the tip. The balloon typically holds 10 ml of sterile water, sometimes 30 ml for special 3-way catheters. Never use saline to inflate the balloon, to fill the balloon. It can crystallize and make removal difficult. Never inflate the balloon until you see urine retain, confirming you are in the bladder. The drainage tubing and bag form a closed system. The bag has a drainage port at the bottom and should always hang below the bladder level. Never place it on the bed or above the bladder as this causes backflow and increase the infection risk. Some systems have anti-reflux valves built in. 3-way catheters have an additional port for continuous bladder irrigation, commonly used post-TURP or in patients with significant hematuria and clots. A caudé Foley catheter is a type of Foley catheters with a slightly curved or bent tip designed to maneuver around blockages such as in enlarged prostate or to navigate a narrowed urethra. Unlike a standard straight-tipped catheters, the bent tips help pass through the urethra and into the bladder, making it useful when standard catheters fail to be inserted successfully. I'm not going to discuss the insertion procedure itself in this video, but remember the following. Never force the catheter. Resistance in males is common at the external sphincter Ask the patient to take deep breaths and bear down slightly. If you still meet resistance, stop. You might be dealing with urethral strictures, enlarged prostate, or false passage. Get urology involved here. You should see urine return before inflating the balloon. Remember that. If you do not see urine, do not inflate the balloon. You might be in the urethra, which can cause serious trauma if you inflate it in the urethra. Once the balloon is inflated, gentle traction should be applied to ensure the balloon seats at the bladder neck. You should feel resistance. This is normal here. And document the size of catheter, balloon volume used, and the patient's tolerance of the procedure. If insertion was difficult or traumatic, look for gross hematuria. A small amount of blood-tinged urine is common, but frank blood or significant hematuria needs urologic evaluation. Now, what are the daily bedside checks when routing on patients with Foley catheters? Every single day, we should be asking ourselves, does the patient still need the catheter? If not, remove it, please. Check urine output and characteristics. How much urine has drained? Is it clear, cloudy, bloody? Cloudy, foul-smelling urine might suggest infection. But remember, colonization is extremely common with Foley catheters and does not always mean infection. Do not treat cloudy urine or a positive culture without symptoms, please. Next, assess for obstruction. Is urine draining adequately? If output has suddenly dropped or stopped, the catheter might be kinked, clogged, or malpositioned. Check the tubing from the patient to the bag. Look for kinks, loops above bladder level, or the patient may be lying on the tubing itself. If the tubing is patent but there is still no output, try flushing with sterile saline 30 to 60 ml. If you meet resistance, do not force it. The catheter might be clogged with sediments, blood clots, or malposition. And don't forget to check the drainage bag position. The bag again must always be below the bladder level but not touching the floor. Never let it rest on the bed rail or hang above the bladder. This causes backflow and dramatically increases infection risk. Inspect the insertion site and securing. Look at the urethral meatus for signs of trauma, erosions, bleeding, or discharge. The catheter should be secured properly. In males, typically to the lower abdomen or thigh, and in females to the inner thigh. Improper securing causes urethral traumas and pain. And please don't forget to assess for patient discomfort. Bladder spasms, suprapubic pain, or urethral discomforts are common. Make sure the patient is not constipated. This worsens spasms. Ensure adequate pain control and consider anticholinergics like oxybutynin for severe bladder spasm. And always screen for signs of infection, fever, tenderness, costovertebral angle tenderness, encephalopathy in elderly patients, etc. But again, remember, pyuria and positive cultures alone without symptoms are not enough to diagnose catheter-associated UTI. The patient needs symptoms and signs along with that. Now, most hospitals have a daily necessary checklist. If the catheter does not meet criteria, put in order to remove it, please. Do not wait for no reason. And this brings me to Foley catheter removal. Removing a Foley catheter is straightforward, but there are things to know here. We should remove the Foley catheter as soon as the indication no longer exists. Do not wait any longer. I cannot stress this enough. Many patients have Foley catheter for no clear reasons. The patient is hemodynamically stable and no longer needs strict hourly urine monitoring, or we remove it when we want to give a voiding trial after treating urinary retention, or if the surgical indication has resolved. Now, how to remove? We deflate the balloon completely first by withdrawing all the water from the inflation port using a syringe and gently pull the catheter out. And if you meet significant resistance, stop, please. The balloon might not be fully deflated or there might be incrustations. Never force the balloon removal, please, if you face resistance. And document the time of removal and instruct the patient to try to void within the next 6 to 8 hours. Monitor for post-void residuals, PVR, if there is concerns for retention. Again, after removal, patients should void within 6 to 8 hours, and if they can't or if they are uncomfortable with suprapubic fullness, check a bladder scan. A PVR, post-void residuals greater than 400 to 500 ml, typically warrants recatheterization, either straight cath or reinsertion of Foley's depending on the situation. Some patients, especially post-op or with BPH, may need a trial of alpha blockers or temporary recatheterization. I typically straight cath them twice, and if they're still retaining urine, I reinsert a Foley catheter and then start tamsulosin and arrange for discharging home with a Foley catheter and outpatient urology follow-up. Let's finish by discussing some pitfalls and warning. Catheter-associated UTI is the most common hospital-acquired infection, and prevention is key here, as we said. Use Foleys only when necessary. Maintain a closed system, remove as soon as possible, and ensure proper hand hygiene. Do not break the closed system to get cultures unnecessarily. If you need a sample, use the sampling port with sterile techniques. Never disconnect the tubing, please. And do not treat asymptomatic bacteriuria, please. Most patients with Foleys will have positive urine cultures. That is colonization, not infections. Only treat if there are systemic signs of infections. Watch for catheter obstruction. If urine output drops suddenly, do not just assume the patient is dehydrated or in acute kidney injury. Check the Foley and the tubing first. Flush it gently. If you cannot flush it or there is persistent obstruction, the catheter may need to be replaced. Hematuria with clots can clog standard Foleys. If a patient has significant bleeding or hematuria, use a large 3-way catheter with continuous bladder irrigation to prevent clot obstruction. And if you decide, remember this, if you decide to do that, please consult urology. I highly recommend against starting CBI without urology involvement. If no urology available, then transfer to a facility with the urology service before starting CBI or as soon as you start CBI. Traumatic insertion can cause urethral injury, false passage, or bladder perforation. If insertion was difficult, or you see significant hematuria, or if the patient has severe pain, get urology involved right away. Never force a catheter, please. Balloon inflation in the urethra is a urologic emergency. Always confirm urine retain before inflating. If you inflate it prematurely, deflate immediately, advance slightly, and try again. If there is trauma, call urology right away. Chronic Foley use causes complications over time. Bladder stones, chronic UTIs, urethral erosions, and increased bladder cancer risk. Yes, it does increase bladder cancer risk. For patients needs long-term catheterization, consider alternatives like suprapubic catheters or intermittent straight catheterization if appropriate. In the end, if you like this video, I'm pretty sure you will like my previous videos, the one I discussed chest tubes in the ICU and also about PICC tubes and NG tubes. Links for both videos provided in the description field. Thanks for watching, and I'll see you soon.